All right, guys, we'll get started. My name is Natalie Robu. I'm an outpatient pediatrician with FQHCs here in Philadelphia, and I am a current Capello Fellow. And I want to welcome everyone here today to our Advocacy Grand Rounds event. And before we get started, I just want to take a quick moment to invite you all to officially join Doctors for America and the DFA fight to improve healthcare for all and become a sustaining member. It's super easy. There's going to be a link in the chat below, and you can select your membership level. You pay your annual membership dues to support DFA's work to improve healthcare with incredible programs like this Advocacy Grand Round series. Tonight, we will be live streaming this presentation on Facebook Live as well as recording it, and all materials will be available afterward. Just a few quick things about this educational session. All questions are welcome. There's no such thing as a silly, stupid question. Please just remember to use the Q&A feature in the Zoom, and we're going to address those questions in the second half of our session. And look out for in the chat along the way because DFA staff is going to be putting some helpful links during the session there. So now on to our speaker. We're thrilled to welcome Larry Levitt. He's a executive vice president for health policy at KFF, overseeing KFF's policy work on Medicare, Medicaid, healthcare marketplace, the Affordable Care Act, racial equity, women's health, and global health. He was previously editor-in-chief in KaiserNetwork.org, which was KFF's online health policy news and information service, and directed KFF's communications. Prior to joining KFF, Levitt served as the senior health policy advisor for the White House and the Department of Health and Human Services, working on the development of the Clinton administration's Health Security Act and other health policy initiatives. And earlier, he was the special assistant for health policy with California Insurance Commissioner John Garamendi, and a medical economist with Kaiser Permanente, and served in a number of positions in the Massachusetts state government. Levitt holds a bachelor's degree in economics from the University of California, Berkeley, and a master's degree in public policy from the Kennedy School of Government at Harvard University. And it's our pleasure to introduce him today, and I'll turn it over to you, Mr. Levitt.
Thanks, Natalie. I think I need to shorten my bio after that. For those of you not familiar with KFF, we're a health policy information organization. Really do three primary things. Health policy research, which I oversee, polling, we're the premier health polling organization in the country, and also journalism through KFF Health News, which is an operating program of KFF. And for those of you who don't get access to our work, you can sign up for all three of those types of information. And our mission is to inform health policy debates like we're going through right now. We do not take policy positions or lobby or advocate. Our goal is to, provide information about these debates, particularly as they affect people. So I'm going to give a brief presentation, and then want to leave plenty of time for questions as well. There are a series of health policy debates going on in Washington right now that could have huge implications for health coverage, access, and affordability. The changes, if everything being proposed and considered right now were enacted, would be on the scale of the ACA repeal and replace effort in 2017, which failed. But there's not much tension to this debate, certainly not as much as there was in 2017. And while the coverage losses could be on the scale of what was proposed in 2017, it has not been labeled that way or framed that way. The components of this debate are a tax and spending cut bill being considered in Congress, known as a reconciliation bill. It has passed the House and is moving on to the Senate. There have also been executive actions from the Trump administration, as well as potential expiration of enhanced premium aid under the Affordable Care Act, which was initiated during the public health emergency during COVID, and is scheduled to end this year if it's not extended. To give you a sense of the scale, just want to start off with how many people could become uninsured if these enhanced premium subsidies under the Affordable Care Act and the reconciliation bill being considered by Congress are passed, as well as executive actions by the Trump administration. And these numbers are frankly already outdated from just a few weeks ago. They're from the Congressional Budget Office because the bill passed by the House actually goes further than what was being considered at the time. The Medicaid changes and ACA changes under the Affordable Care Act, and again, this is just a partial number, would increase the number of uninsured by an estimated 7.7 million people. A proposed regulation by the Trump administration that would make it more difficult to sign up for coverage under the Affordable Care Act and would be codified into law under this budget reconciliation bill. Republicans are advancing would increase the number of uninsured by another 1.8 million. And if those enhanced premium subsidies under the Affordable Care Act expire at the end of this year, that would increase the number of uninsured by another 4.2 million. So 13.7 million, and frankly, upwards of, I would say, 15 million by the time these estimates are updated. More people would be uninsured. This would be by far the biggest increase in the number of people uninsured we've ever seen. This would happen across the country and in every state, but there are certain regional effects. There would, for example, be a big effect in states, particularly in the South, that have not expanded Medicaid under the Affordable Care Act. In those states, ACA enrollment tends to be higher, and people rely to a greater extent on those enhanced premium tax credits or premium subsidies. The biggest coverage loss would actually be in Florida, again, a state that has not expanded Medicaid under the ACA. Texas would be a close second to Florida. Another way of looking at this is the total dollars that would be cut under this budget reconciliation bill being considered by Congress that would cut taxes as well as cut spending to help pay for those tax cuts. Just a portion of the bill that would enact Medicaid cuts would cut Medicaid by over $723 billion over 10 years. And again, this is a lower bound. There were some changes at the last minute made to the bill before it passed the House that would increase the Medicaid cuts. In addition to this, there would be cuts to the Affordable Care Act. When all is said and done, the total cuts to healthcare would be approaching $1 trillion over 10 years. This would be the biggest rollback in federal support for healthcare and health coverage ever, if it's enacted as it passed the House. Now I'm not going to go through all the Medicaid provisions, but there are a long list of changes to Medicaid in this reconciliation bill. But I do want to highlight a few of them that would particularly affect low-income people covered by Medicaid. One would allow cost sharing for the first time up to $35 per visit for people with incomes above poverty. So these are people with very limited income and could be facing cost sharing at state options up to $35 per encounter. The legislation would repeal a whole series of Biden administration regulations that affected Medicaid. It would repeal a regulation that required increased staffing in nursing homes, as well as regulations that would make it easier for people to enroll in and renew their Medicaid coverage. It would require renewals, which are currently every 12 months in Medicaid, to be every 6 months. So people would have to go through a verification and renewal process every 6 months. And what we tend to see is when people go through those renewal processes, they tend to fall through the cracks. So the more frequently people have to renew coverage, the more red tape they have to go through, the fewer people and end up covered. And then finally, and I'll talk about this a little bit more, would be work requirements required in every state for the first time in Medicaid. So these work requirements would require 80 hours per month of work or community service. There would be a series of exemptions, including caregivers, people who are disabled, people in substance abuse treatment program. In many ways, this is a solution in search of a problem. 64% of adults on Medicaid are already working. Another 28% would likely qualify, at least in theory, for one of the exemptions. So 92% of adults covered by Medicaid now are working or would likely qualify for an exemption, leaving just 8% who would be in some ways a target for this work requirement. But even though very few people, Medicaid enrollees, would be subject to this work requirement, or really I would call it a reporting requirement, many people would end up falling through the cracks and lose coverage. Arkansas was one state that implemented a work requirement under a waiver of federal rules during the first Trump administration. That was ultimately overturned by the courts and pulled back by the Biden administration. But for the brief time it was implemented, many people lost coverage, again, not because they weren't working or didn't qualify for an exemption, but because they could not meet the reporting requirements. In Arkansas, even particularly in the early days of implementation, reporting was required online, and the website where you had to report was only open during business hours. So closed during the time that people who would ordinarily be working, potentially in jobs where they did not have easy access to the internet, would have to report their work. This is in many ways a kind of rationing coverage by complexity. Importantly, the various estimates, including estimates by the official Congressional Budget Office, project that there would be no meaningful increase in work from this work requirement. The savings to the federal government, which would total roughly $300 billion over 10 years, would come from people, again, who were working or would qualify for an exemption, but end up losing Medicaid coverage, with millions likely ending up uninsured. A big aspect of this debate, framing by Republicans, has been that Medicaid, particularly the Medicaid expansion, where the work requirement would apply, covers able-bodied people who aren't necessarily deserving of health care, and to qualify for health care should be working as able-bodied individuals. This reflects a long-standing ideological divide between among critics of Medicaid, who see it as a welfare program for the deserving poor, and advocates for Medicaid who see it as a stepping stone towards universal coverage, and part of a system where people have a right to access to health care. That debate aside, which really drives this debate over work requirements and Medicaid cuts, the truth is that many people covered by Medicaid, and particularly the Medicaid expansion, are not necessarily able-bodied. In fact, 44% of adults covered by the Medicaid expansion, have a physical or behavioral chronic health condition. Now, these are not necessarily conditions that would prevent someone from working, but they are certainly conditions that require access to healthcare. These cuts to Medicaid, the work requirements, are being advocated by Republicans. It passed the House with no Democratic votes. But the Medicaid expansion, is not simply a blue state issue. All the states that have not expanded Medicaid, primarily in the South, states like Florida and Mississippi and Georgia, and Texas, are in fact red states. But among the states that have expanded Medicaid, which is 41 states, including DC, it's a mix. In fact, it's split almost equally between red and blue states. So these work requirements, in particular, would have an effect across the country in states that expanded Medicaid in red and blue states alike. Similarly, as Medicaid has expanded, and as the Republican political base has expanded as well, with more voters in so-called working class voters, Medicaid enrollees have become more diverse politically. And what that means is that there are many congressional districts across the country with a substantial number of Medicaid enrollees, and those include Republican as well as Democratic districts. Some of them are in swing districts in states like California and New York, but many of them are in very Republican states, very Republican districts. For example, Speaker Mike Johnson in the House, his district in Louisiana has one of the highest number of Medicaid enrollees in the country. This did not prevent the bill from passing the House, but could certainly play a role as it moves to the Senate and then back to the House to resolve any differences. So I want to switch gears a little bit to the Affordable Care Act. The ACA marketplaces have seen tremendous increases in enrollment in recent years, and this really dates to 2021 when these enhanced premium subsidies, increased tax credits were enacted by Democrats in the House and the Senate and signed by President Biden. Enrollment has doubled since 2020 from a little over 11 million to over 24 million people. Now, interestingly, that growth has been overwhelmingly disproportionately in red states, in states that President Trump won in the last election. And the reason for that is that those states, particularly in the South, tend to be states that have not expanded Medicaid. So what that means is low-income people, people below poverty are locked out of coverage entirely. They're not eligible for Medicaid if they are adults without children, and they're not eligible for premium assistance in the Affordable Care Act marketplaces. But for people with incomes between 100% of poverty and 138% of poverty in those Medicaid non-expansion states, they are able to get premium assistance in the ACA marketplace. If their state had expanded, they would otherwise be in Medicaid. Importantly, this enhanced premium aid applies across the board to ACA marketplace enrollees, but it's particularly powerful for people in the income range 100 to 150% of poverty because the enhanced premium aid provides a full premium subsidy for people. So people, if they enroll in a benchmark plan, pay zero out-of-pocket premium, and particularly for low-income people with very little to no discretionary income, being able to get coverage for zero out-of-pocket premium cost is quite powerful. Now, to give you a sense of how much this enhanced premium assistance matters, on average, the extra premium aid averages $705 per person per year. If the premium aid expires at the end of this year and is not extended by Congress, people would be facing, on average, out-of-pocket premium increases of over 75%. So you can see why over 4 million people would end up losing coverage because they can no longer afford it. This applies throughout the income spectrum, but it varies somewhat by income. In dollar terms, and certainly varies as a percent of income. So if you think of someone, 45-year-old with income of 166% of the federal poverty level, that's about $250,000 per year, they would be facing a premium increase of $917 per year. A substantial hit, a pocketbook hit for these low income people. As I said, this premium aid expires at the end of this year. It has not been a part of the budget, the tax cut and spending cut debate in Congress so far. Historically, Republicans have been opposed to Obamacare or the Affordable Care Act. But they also know that their constituents could see these big premium increases right before the midterm elections. So there may be pressure as the year progresses for at least a short-term extension. A permanent extension of the subsidies would cost over $300 billion over 10 years. Now, there are other changes to the ACA potentially in store in addition to these premium subsidies. expiring at the end of the year. Many of the changes, like those in Medicaid, in the reconciliation bill that has passed the House, revolve around more paperwork, more red tape for people to sign up for coverage and renew their coverage. So, for example, there would be increased verification before people could qualify for coverage to demonstrate their income, their family circumstances. And this would particularly occur if someone's income is different from what, let's say, public government records show, which happens quite often, particularly for people in pretty volatile economic circumstances. The bill would end automatic renewal of coverage at the end of the year. So right now, during open enrollment, which occurs at the end of the year and into the beginning of the following year, people can go on to healthcare.gov or their state-based marketplace and affirmatively renew their coverage, change their plan, change their deductible. But if they don't, they are automatically renewed into coverage. The bill, the House passed reconciliation bill, would end that automatic renewal, potentially leaving millions of people falling through the cracks and not having their coverage renewed. Combined with that, the bill would shorten the open enrollment period substantially, leaving people less time to renew their coverage. And in the end, millions of people could end up losing insurance. Another provision in the bill would end caps on how much of their premium subsidies people might have to pay back when they do their taxes. And I'll back up just a little bit. These premium subsidies come in the form of tax credits, refundable tax credits. They offset your taxes, or if you don't owe taxes, it's money back from the federal government. Obviously, low-income people can't afford to wait until the end of the year to get a premium subsidy to afford coverage. So there are what are known as advanced premium tax credits. So people qualify for these based on their estimated income for the year, and they get help paying their premium on a monthly basis. Then when people file their taxes, their premium subsidy is reconciled based on their actual income. So if their income goes up, they might owe money back to the federal government, or if their income goes down, they might get money returned to them. There have been, since the beginning of the Affordable Care Act, caps on how much people might owe. The House bill would eliminate those caps. So if you look at someone, let's say, whose income, they expect their income to be just above the poverty level, let's say $16,000 a year. If their actual income falls to $15,000 for the year, just below the poverty level, they would no longer be eligible for a premium subsidy and could end up having to pay back almost $6,000 a year, or over a third of their income, which would be prohibitive for someone at that income level. Another theme in both executive actions by the Trump administration and in this reconciliation bill being considered by Congress is looking to restrict immigration and the benefits available to immigrants. And there are a number of provisions in the bill that would do that. And I want to be clear, undocumented immigrants are not eligible now for Medicaid or Affordable Care Act coverage. Medicaid does pay hospitals for emergency care provided to undocumented immigrants who have low incomes, but people are not eligible for coverage. But 14 states, including DC, have used their own money, so own state money, no federal money, to provide coverage to undocumented children, and in some cases to adults. The House bill would penalize states that have used their own money to provide coverage to undocumented immigrants if they continue to do that. The penalties, which would come in the form of reduced federal contributions for Medicaid, would total $92 billion across these 14 states over 10 years. And there are over 1.9 million people covered in these state funded programs for undocumented immigrants. So $92 billion is obviously a lot of money. The expectation is that many of these states would end up ending coverage for immigrants, and about 2 million people could lose coverage. There are other provisions that target lawfully present immigrants. So, for example, there's currently a 5-year waiting period for lawfully present immigrants to qualify for Medicaid. But during that 5-year waiting period, people qualify for coverage through the Affordable Care Act. That coverage would be eliminated. So people during that 5-year waiting period would qualify for no coverage whatsoever. DACA recipients who are currently eligible for coverage in the ACA would no longer be eligible. And, kind of for the first time, there would be a rollback in eligibility in Medicare with immigrants, including refugees and asylees who are currently eligible for Medicare, no longer being eligible. These cuts targeted at immigrants are not where a lot of the dollars cuts come from, not where a lot of the loss in coverage come from, but they've been a very prominent part of Republican talking points, and in many cases, likely resonate with the public. Now there are other specifics like work requirements that also resonate with the public. Our polling has shown that work requirements are generally popular across the political spectrum. That support for work requirements tends to drop if you present people with information about how many people might lose coverage, the red tape that people might have to go through to report their work. But work requirements are likely a relatively popular part of this bill. But in general, people across the political spectrum are extremely opposed to cuts in Medicaid. And in many cases, I think that comes from people's personal experience. Our polling shows that over half of people say they've been covered by Medicaid themselves, or a family member has been covered by Medicaid. So, Medicaid is a very broad program that affects a lot of people. And I think that drives people's nervousness about cuts. Now, I will say that despite this public opposition to cuts in Medicaid and the ACA, this bill is moving forward, frankly, without much public debate, and it's moving forward quickly. The House just passed the bill. The Senate hopes to pass this budget reconciliation bill by July 4th. The Senate may moderate the Medicaid and ACA cuts some, but at least as of now, it doesn't look like they would moderate them by much. President Trump is one big wild card here, as I guess he is with almost everything. Back in 2017, during the debate over repealing and replacing the ACA, after a version of ACA repeal passed the House, President Trump held a party in the Rose Garden celebrating passage, but then within days, when there was public backlash, said it was mean and had to be altered. In the late stages of the debate in the House this year, President Trump posted that Republicans should not F around with Medicaid. They, in fact, did, and in fact, increased Medicaid cuts in the bill that ultimately passed. There has not been a big public outcry against these changes yet. But if there is, it would have to happen quickly. If there is, President Trump and Republicans, could end up backing away from big healthcare cuts like they did with ACA repeal in 2017. If not, we would see the biggest loss in health coverage, frankly, we have ever seen. So I'm going to stop there, and I would be happy to take any questions.
Thank you so much, Mr. Levitt. Appreciate all your insight into this. Obviously, very complex situation in times where there's really a lot of uncertainty. So thank you so much. Please, everybody, remember to use the Q&A feature in order to submit your questions. I'll start with the first that we have. So if people were angry about universal health care denials of care, how do we make them understand the impact of the proposed cuts in abandoning people and channel their efforts accordingly?
Yeah, well, it is. I think it's hard, and it's partly because these changes are very complicated, and I didn't even go into all the changes, but the work requirements are complicated. They may sound good, but result in people losing coverage. There are other provisions like a moratorium on taxes on hospitals and nursing homes that states use to help fund their Medicaid programs. Changes in income verification processes. These are very hard to put on a bumper sticker and for people to organize around. I think the easiest thing for people to grasp are the top line numbers. I mean, the idea that 13, 15 million people could lose health insurance as a result of these cuts. In debates like this in the past, and to some extent in this debate, healthcare providers have been active. Physicians, nurses, hospitals, nursing homes, who stand to lose, paying patients and to have their patients lose access to care. Those groups have certainly been active on the Hill opposing these plans, but have not. Uh, I would say have not ratcheted up their opposition up like they have in some previous debates.
Thank you. Related to the potential Medicaid work reporting requirements, would the disability exemption be determined by whether an individual is on Social Security disability?
So the work requirement applies only to the Medicaid expansion group. So people who are disabled under SSI, qualify for Medicaid based on a disability, would automatically be exempt. But there are other exemptions for illness or disability that would not be automatic. And it's a little unclear how those would play out. The legislative language refers to states automatically qualifying people for exemptions to the extent they are able to. I think states will vary a lot in how aggressive they are at making it easy for people to qualify for exemptions. States would have to qualify people for the work requirement or for exemptions at least every 6 months, but they could do it as often as once a month. So a lot would depend on how this is implemented, what regulations would be issued by HHS, presumably under the Trump administration, and how much leeway states would have. So, for example, for an illness or a disability, I think it's some states might allow just people to attest to that if the federal government allows them to. Other states, I would imagine, would be much more stringent and require doctor notes. And it may be that HHS just doesn't allow much state leeway at all.
Could you review where the current data is on the cost argument for keeping people insured? Specifically, the evidence stands on whether the ACA ultimately saved money as less people are going to the ER, more people are getting good preventative care. Curious if this could be an additional talking point when advocating against these cuts.
Yeah, I think it's really important when we talk about healthcare costs to talk about healthcare costs for whom. So the Affordable Care Act certainly costs the federal government money. I mean, healthcare spending by the federal government went up for the Medicaid expansion, for these premium tax credits that help those 24 million people get coverage through the ACA marketplace. The ACA had ways of paying for that. So at least when the ACA passed, the estimate was that it would reduce the deficit and produce net savings for the federal government. There was on the other hand, the Affordable Care Act has certainly lowered the amount people spend out of their own pockets on healthcare. People are having their premiums subsidized. People are getting covered by Medicaid. It's lowering their out-of-pocket costs, lowering their levels of Medicaid debt, improving their financial security overall. There were expectations that the ACA would accelerate health spending growth. That with more people insured, they'd be using more health care, and that would produce put a burden on the system, put a burden on access for other people. That did not happen. Health spending growth has actually slowed since the Affordable Care Act passed. I think there's no question, and there's a large body of evidence that the ACA has improved people's financial security, lowered their out-of-pocket costs, improved their access to care, improved mortality, lowered premature deaths, improved, lowered hospital sensitive conditions, access sensitive conditions for hospitalization. Things like emergency rooms are a little trickier. In general, when people get insured, and most of the evidence shows this, people actually use the emergency room more than when they're uninsured, because now they actually have access to care. So people tend to avoid the emergency room when they're uninsured, even when they need it, only ending up to go to the emergency room and they really, really need it. And I think similarly with prevention, prevention certainly keeps people healthier. There are some cases where prevention ends up lowering costs, but I think in some ways we oversell prevention as a way to lower costs rather than as a way to just make people healthier.
You mentioned that some states would especially suffer coverage losses under the Medicare and Medicaid cuts. Are there some states that are equipped to preserve coverage more than others if this should happen?
I think, it's interesting that the Congressional Budget Office, which is the kind of budget referee in Congress, has assumed that states would pick up half the cuts in federal spending in Medicaid, so that half the cuts would be offset by states and preserve coverage for people. Um, to me, that's very optimistic. We're talking about a lot of money. If we're talking about $1 trillion in federal health spending cuts, states are going through a period now where their revenues are struggling. I don't think there are many states that would honestly have the capacity to offset these cuts. But I think, with these Medicaid cuts, it would unleash a big debate in many states about how to respond. Some cuts might even push states to cut even more, given the leeway to do so. And on something like work requirements, I don't know that any states would simply cover people um, who fall off Medicaid due to the work requirement using their own money, but I think some states would certainly be willing to implement it in a more patient-friendly way to reduce the effects.
Um, if this bill passes, the Senate as written, 13 to 15 million people will lose their health coverage. What do we expect this to do for healthcare costs for those who do get insurance through their employer?
Yeah, so this I think the effects on people with employer coverage, at least the direct effects, would be minimal. There's nothing in these bills that would directly target employer provided health benefits. But there could certainly be indirect effects. I mean, coverage loss of that scale, upwards of 15 million people, would increase uncompensated care. It would increase medical debt, put pressure on hospitals, particularly rural hospitals that are operating on a shoestring, could end up closing. There would be pressure on hospitals to make up for these cuts in Medicaid by increasing prices for commercially insured patients, which would increase costs for employers and then downstream increase costs for patients as well, with higher deductibles, higher premium payments. So it would be hard to eliminate health coverage for 15 million people and not have broader effects in the health system.
What can we do? What do you think is the most effective way to fight for this as clinicians who are advocating for patients and our own families? As full-time physicians, how do we prioritize advocacy on these topics?
I think physicians are incredibly effective advocates because they are seeing patients one on one, and can put a face on these these kinds of cuts. And that's frankly part of what's been missing in this debate so far, is the tangible effect on people. It's been a debate about numbers, not a debate about people. So, you know, being able to emphasize what coverage means for people, coverage through Medicaid or the Affordable Care Act, how it's made a difference in patients' lives, um, the difficult circumstances that many low income patients are in, with uncertain economic circumstances. Combined with health conditions that might make it difficult to navigate something like a work requirement. There was a story that came out of Arkansas about a man who ended up losing his coverage. Kind of spiraled. His life spiraled from there. He had been working, could no longer be working. His health worsened. Being able to help people understand what patients in these circumstances might have to go through, I think, can be very effective.
Can you explain the right's rationale for asserting that ACA has increased costs for patients in the healthcare system?
Well, it's not true. I'm not sure I can explain the rationale. I mean, conservatives point to, for example, high deductibles under ACA plans. Um, those high deductibles have always been there for people who buy insurance on their own. Paying fully out of their own pocket. If anything, the ACA has lowered them by providing increased assistance, by helping people pay their premiums, allowing them to buy a plan with a lower deductible. There were, I think, valid criticisms when the ACA first went into effect, that guaranteeing coverage for pre-existing conditions, guaranteeing a set of essential health benefits in all plans for things like mental health and substance use and maternity, increased premiums. And that is certainly true. Plans that people bought on their own before the ACA were cheap, but they were cheap because they didn't cover things. They didn't cover pre-existing conditions. People with pre-existing conditions were often denied insurance altogether. They didn't cover maternity care. They didn't cover mental health. They often didn't cover prescription drugs. So there was this period when the ACA first went into effect that people, particularly people who did not qualify for premium assistance, saw their premiums rise. Similarly, the ACA prohibited surcharges based on health status. So people who were healthy kind of benefited from the fact that people who were sick paid more. People who were younger benefited from the fact that people who were older paid much more. So those changes increased premiums for some, while of course decreasing them for others. And there was a group of middle class people who bought insurance on their own. So these are small business owners, farmers, entrepreneurs who initially didn't qualify for any premium assistance under the Affordable Care Act. That premium assistance capped at 4 times the poverty level, and they really felt the brunt of those initial premium increases. One of the things the enhanced premium aid passed in 2021 is made people above 4 times the poverty level eligible for assistance for the first time. So their premiums were capped at 8.5% of their income, and millions of people have gotten subsidies through that provision that would end after this year if they expire.
I think this is a more of a messaging question. So before the AC had gone into place, Republicans decried death panels, even though there was no such thing. Now there's a policy that they're proposing that's actually going to cost lives, and it seems like the Democrats aren't protesting as loudly. It seems like one of the messaging, even if not true, is very strong and very critical, while the other side is reluctant to be as critical or harsh. I guess the question was why? Why is that? That maybe the messaging is so different.
Um, eh, eh, the I'll talk about the Republican messaging first for this bill. And it's been, as I mentioned, kind of very focused on immigrants. what they call illegal aliens, and all this federal money going to them, which is simply not true, since they don't qualify for coverage. There's been this focus on able-bodied people, making it seem like somehow the federal government is wasting money on them. Particularly focus, interestingly, many women qualify for Medicaid, including under the Medicaid expansion. But the focus has been on young men sitting on the couch playing video games, not going out to work, not getting a job. The responses to those end up sounding very complicated. As you saw from my presentation, kind of piercing that misinformation with facts is not as simple as the misinformation to begin with. And honestly, I think that's a challenge in general in combating misinformation, whether it's about death panels or Medicaid cuts or immigrants or vaccines. It is the facts are more complicated than the misinformation. It's we'll see. I expect this debate to change somewhat as it goes to the Senate. It's going to happen extremely fast, potentially over the next few weeks if they're successful. But in the House, it's a very regimented process. There was not a lot of opportunity for public debate. It moved through very quickly. It's the focus, as I said, was kind of on these numbers. And it's been, I think, hard for Democrats and advocates to put a face on those numbers.
Which parts of the bill are the highest yield for us to focus on when advocating with senators, as some Republican senators may be concerned about these changes and thus more swayable to vote against it?
Yeah, that's a good question. So the provision I talked about, allowing copays up to $35 for people with incomes at the poverty level, has already gotten some pushback. Senator Josh Hawley, who is hardly left of center, has criticized that, and in fact criticized Medicaid cuts generally, although he has said he supports work requirements. There are provisions which I didn't mention, specifically targeted at abortion coverage and Planned Parenthood. The bill would eliminate Medicaid payments to Planned Parenthood. Those are not generally for abortion because there are only very limited cases where Medicaid pays for an abortion. Those are payments for family planning, for STD screening, for other types of care. Would eliminate those payments. And Medicaid represents a substantial share of Planned Parenthood clinics of budgets. There is also a complicated provision that would essentially limit federal payments to health insurance plans that cover abortion. And that's true, particularly in about a dozen states that require health insurance plans to cover abortion. And that would set up a clash between the federal government and states. If states preserve that requirement to provide abortion care, they would be turning their back on billions of dollars in federal payments and likely collapse the ACA marketplaces in those states. I think that could potentially be an issue that senators like Senator Collins and Senator Murkowski, the only pro-choice Republicans, might have an issue with. There's also a complicated issue of provider taxes. These are taxes that I mentioned on hospitals and nursing homes that help states fund their share of the Medicaid program. There's a moratorium on those taxes in the bill. I think there are certainly some states, particularly rural communities, where those taxes and then the payments to the hospitals and nursing homes that the taxes enable could end up being a politically important issue.
That's all the questions that are in the chat. So we still have a few minutes. So if anyone has any additional questions, please ask them. I would like to ask a question, like working for a federally qualified health center where we are kind of the safety net for uninsured. You know, just trying to think what that might look for a center like ours where I can imagine the influx of people is going to be much higher. And I can already tell you now we're very short staffed. I mean, weights and things like that are, through the roof. I'm just wondering, any thoughts on, what's going to happen in that area.
Yeah, I mean, nothing good, right? It's and I think it's I mean, almost every hospital, almost every physician has some Medicaid patients, um, uh, but they are not distributed equally by any means. Some hospitals are safety net hospitals that care for a lot of Medicaid patients. Um, Health centers, certainly serve a disproportionate share of Medicaid patients. So I think the biggest brunt would fall on those healthcare providers, and won't be uniform geographically either. So, for example, in communities with high immigrant populations, the effects could be quite dramatic, even if the national numbers of reduced coverage among immigrants aren't that large.
I'll get back to you because that's my whole patient population. I'll keep people abreast on that. And other questions came through. Do you see safety net hospitals closing because of these Medicaid cuts?
I think in general, I'd say safety net hospitals in urban areas are unlikely to close. In some cases, those are public hospitals, the or teaching hospitals. With a broader patient base. Rural communities are another story. The hospital margins on average are relatively healthy right now. That is certainly not true everywhere. And rural hospitals and rural communities have increasingly relied on Medicaid with the Medicaid expansion. So I would be very surprised if some rural hospitals don't close as a result of these cuts.
Is there anything in the bill that speaks to not funding specific treatments like mental health services?
So the only one I can think of offhand is treatments for gender affirming care, and it would prohibit Medicaid from paying for that.
Are there quantitative estimates for facility closures due to increase in uncompensated care for lack of Medicaid payments?
It's a good question. I'm not aware of any. I've heard of some people working on those estimates, so stay tuned over the next few days. But I have not seen estimates of that specifically yet.
If care is removed, how do we propose that the federal government should then provide an alternative? What is their healthcare policy plan versus just tearing things down?
Well, it's interesting. In 2017, I mean, the 2017 healthcare debate started as an ACA repeal debate, pure repeal. There was a lot of pressure on Republicans for what they would replace it with. So it became at least called a repeal and replace debate. And there were at least elements of alternative approaches that Republicans put on the table then. That has not been true at all this year. I mean, this has been a debate about cuts, with frankly, nothing to replace the coverage or care that's being cut. And I think part of why this debate has been different is, in 2017, it was a bill about healthcare. It was a bill about repealing the Affordable Care Act, and frankly capping federal spending on Medicaid as well. This is primarily, or people think of it primarily as a tax cut bill, a bill that extends the Trump tax cuts and adds new tax cuts. The healthcare part of it, the spending cuts, are a way of helping to pay for those tax cuts. So the debate has not been so squarely focused on healthcare as it was in 2017.
And that's all the questions in the chat. Thank you so much, Mr. Levitt, for all your expertise. I think a lot of the information we've gotten is definitely super motivating for us to be more involved in speaking with our legislators. And I know it's been a discussion with amongst a lot of people in DFA. Like we need to maybe be talking about this in the exam rooms and letting patients know that these are the things that are coming down the pipeline. Like let your let um, congressional people, legislative people know that these are not the things that you want to, be done to your health insurance. So hopefully we have more insight into the data now that we can do that. Um, just a couple more things to just tie up. Please remember to complete the survey in the link below so you can get your CME credits. Please follow DFA on Twitter, LinkedIn, Instagram, Blue Sky, and Facebook to stay engaged on the DFA programs that are going to be coming up and ways to stay engaged. We really want you to take what you learned today and please contact your legislators to protect Medicaid. There's an action alert on the DFA website, which we encourage you to use. It will connect you with your local legislators. And we encourage you to try and schedule virtual interviews while the senators' offices are going into recess from now until June 2nd, I'm sorry. Please write op-eds, letters to the editors for your local paper, get the word out, and share what you learned with your colleagues and friends. Thanks again, everyone, for being here. If there's any questions, me and Sophia are happy to stay a little bit after the grand rounds to address those for you. Thank you so much, everyone. Thank you, Mr. Lovett.
Great, thank you.